Thank you, Andrew. It's a pleasure to be here, and Singapore always is a wonderful city to be in. Uh, Thank you for the invitation. Healthcare and education is actually a citizen's fundamental right. So every government kind of deals with it differently. Some of them take care of the entire burden, and the private sector has a role to play, but not as important as a role. While in countries like ours, and most of my thoughts or comments would probably be about the Indian subcontinent because we deal with 1.3 million population. It would it would be the fundamental right, but the private sector actually takes on a much larger burden than the government, simply because the government over the years, and it's quite a young government, did not realize that the healthcare burden is so intense or so large. And we just enjoyed and lived with the British legacy and didn't really understand that we needed to catch up till probably 15 years ago. And now we see a huge shift with the government and the national policies working towards really taking on the country's burden. But I think there's a bit of a suspicion between the public and the private sector, and once those ideologies converge a bit more, we'd see much more happening. So that's the scenario in India. But Asia itself is huge, and for us to even understand that, we're talking about 11 time zones, and we're talking about 9,600 kilometers. We're talking about 8,500 kilometers north to south. So that's kind of large, and that's the area and the expanse. But it's probably more, much better for us to focus, and we will really focus on what's happening in our subcontinent, which I mean India, and maybe draw some parallels with successful models which have happened in other countries, and which could be probably replicated not only in the emerging markets or in the developing nations, but may have answers even for the so-called developed countries. So everybody knows it. It's nothing new, but it's something which we're constantly trying to focus on, because that's really where we need to find the solutions. We have 0.9 beds every 1,000 population, while where we are sitting, it's 3.1. I know it's a small country, but Singapore, in terms of policies, focused much, much earlier on healthcare. And that's probably why, healthcare per se is not a huge issue. The delivery of healthcare is not such a big issue, as much as the fact that, the NCDs are catching on, the diseases are catching on. So, can we sustain that is an answer for the future. Again, we don't have enough manpower, skilled manpower. Countries like Afghanistan, I mean, they're virtually non-existent. Countries like India needs manpower, and we're looking at solutions to use technology to train more manpower, and maybe use technology sometimes to even replace manpower where it's required. And of course, policies. As I said a little bit earlier, only 15 years ago did the country even, wake up and realize that we needed to have newer, more contemporary, more robust policies to deal with the healthcare burden of the nation. And I think while there are healthcare policies, we need to find how much of that can be sustainable, how much of it probably needs to change, become more contemporary, and how much of technology and newer systems can actually be adopted. So that's where the challenge is. The NCD burden, I think, is probably something which you've been hearing a lot about. But that is probably the single most disastrous killer which can really overtake the economy, the healthcare systems, the progress in nations. And I personally don't think enough has been said. I know we are with FT Asia, but I'm constantly asking the media and telling them, requesting them, that they haven't been responsible enough to talk to people about the burden of not looking after themselves, whether it's whether it's cardiac disease or diabetes or early detection and prevention of cancer, because these are the single largest killers. They cost human lives, and it's an economic burden, whether it's the public sector or the private sector. Somebody is paying for treatment, somebody is paying for care. And I don't think enough is being said about it. So one of the proposals which we're actually making to the government of India is that if they can mandate, if they can actually bring about some kind of legislation where airtime on electronic media, space in printed media can be made available for just public awareness. And it's not advertising, because it will not have any particular organization's name, but I think it has to be mandated. And I'm very hopeful that something like this will happen. This again is about raising awareness, and for us to let people know it's very important for them to really move the needle on where we are on the NCDs. So I think that is again one of the interventions. Swachh Bharat is a very exciting program which has happened with the new government in India. If you come to one of the cities in India, you will find centers of excellence providing the most fantastic healthcare, the greatest of outcomes. And people from other countries come. We have medical tourism, and India is like one of now the preferred locations for people to come for their healthcare needs. But unfortunately, if you drive even 200 kilometers, 50 kilometers maybe outside those urban cities, it's still a challenge for good, clean drinking water. If you drive into one of the not so nice areas, what we hate saying slums, but we don't have a better word, drinking water is still a problem. So basic amenities is still a problem. So that's why Swachh Bharat came into being, and there is a certain amount of, they call it the Swachh Bharat cess, but on every bill there is a certain amount of money which actually goes towards the central pool, which is now allocated to make a change, to make a difference. Besides cleaning up, there's a lot of focus on the environment. There's a lot of focus on providing clean drinking water to the public, and eradication of waterborne diseases like malaria and so on and so forth, mosquitoes, malaria. So I think there's a very clear-cut direction, clear-cut intervention been done in terms of policy by the government, and I think that's really made a huge difference where it has to be done. One of the most fascinating interventions, again, was what was happening in the UAE. Wikaya, which is Arabic for prevention, has become a big movement in those areas, because it was found that people, because of sedentary lifestyle, not very great eating habits, were also prone to lifestyle diseases, especially hypertension, cardiovascular, and undetected cancer, because they kind of held away from even going for early detection. So Wikaya was again is a government initiative, but now the UN, the WHO, and surprisingly the IOM and the World Economic Forum has kind of shown a lot of interest and certified it. So I'm just saying this because I think globally we need to raise the awareness on NCDs for sustainability, because I don't think any government, any population can foot the bill of an epidemic of this kind and of full-blown diseases of this kind. So early intervention on prevention of disease has become a huge global responsibility. The next big challenge is aging. Asia is dealing with a large aging population. We talk about Japan because technically Japan is probably the only one who's woken up, realized, and spoken about the aging population. So we have data on Japan. We have the fact that there's a 4 times increase in the aging population. We have numbers on the age population. And then we know that, Japan has actually done something in terms of intervention for the age population. And in Asia, Japan is probably the first country to even focus on the aging population. But I worry about large nations like ours, because right now India has the largest young population, largest English-speaking young population. But after 3 decades, the young population is going to be termed as an aging population, and we don't have answers for it. So if we're talking about sustainability, we're talking about the burden of disease for the young population, the middle-aged population. I think there's a whole host of initiatives which has to be done for the aging population. And probably the only answer now, of course, apart from better lifestyle and looking after themselves, is a long-term care insurance. Japan has it, and it's actually very well done, LTCI, and certified globally as one of the best models. And I would strongly say that the next countries, the other countries who have this concern have to look at ways and means of looking at it. In terms of what it can do from an economic perspective, in terms of a business perspective, it's huge. It's a $20 trillion business if somebody wants to do and focus on the aging population. But I think that's a completely different conversation altogether. The manpower gap is again a global challenge. Whether it's the developed nations or whether it's countries like ours, the manpower gap is huge. We find that you can build beautiful hospitals, you can equip them, you have enough of devices, pharma coming in with products, but what we don't have is enough doctors, enough nurses, enough allied healthcare workers for India itself. But strangely enough, the doctors, nurses, which India trains, are immediately leaving the country and going away because they have better prospects, whether it's in the UK or in the UAE. They paid 10 times more their salary, and why would they not go? So India has actually become a center for training and churning out manpower for other countries' needs. So how do we really skill people better? The physical infrastructure for the training needs is still not adequate enough, but the e-learning solutions have gotten better because there's a whole gamut of technologically savvy systems available in India. Whether it's especially in the southern states and maybe Gurgaon, and the e-skilling and the e-learning. My organization itself has trained about 40,000 students to be just diabetic care nurses, diabetic care doctors, because we know that's a problem. We do e-learning programs for the governments, and I think this is picking up because this is again a solution to try and bridge the gap of adequate and skilled manpower. But apart from that, we still need physical infrastructure, physical training institutions for doctors, nurses, and allied healthcare workers. And I must say that the present government has now woken up and realized that there is a problem, but we haven't really come up with solutions yet to find answers for the problem. Again, policies, we're typically at the crossroads. And a lot of what I'm saying is pertaining to India because, we've been working in the private sector, we've been in the business of healthcare for 30 years, and our businesses really span not only hospitals and clinics, but it also spans education and newer models of what we can do to raise the health indices in a small population and try to find solutions for the rest of the country. So I think healthcare policies are what need to be looked at, because if we have to sustain for the future, then the policies have to be good and the policies have to be sound. And how do we address that? Singapore, of course, is a country which is admired globally. The right policies at the right time, the right amount of discipline. And even though it's a small nation, I think everything was done right at the right time, and especially on affordable healthcare. Anyone can walk into a private or a public healthcare system. There is a system of co-pay which is mandated, and everybody has to pay for healthcare, even though it's a small amount. And so it just makes them more accountable and more responsible. Thailand introduced the Universal Coverage Scheme, the UCS, and I think that is gaining momentum, and that is being looked at globally as a model for the developing countries. We did something interesting in a place called Aragonda, and that I think is slowly gaining recognition. Aragonda is where my father, Dr. Reddy, came from. Dr. Reddy is our founder of the Apollo Hospitals group. And one of the first things which was done about almost 10 years ago was an insurance scheme for the people for healthcare, which was at 1 rupee a day. So for 365 rupees, they could access 20,000 rupees of healthcare at that time. But today they can pay for a bypass surgery in our country. But this model now has come in many different forms, in many avatars, and more in the southern states, I think, because the southern states have adopted this very quickly and are quite manageable as states. And so we have schemes for the farmers, we have schemes for people below what we call the poverty line, people who earn less than $100 a year, and all of them have some kind of insurance or the other. At least 60% of the population have some kind of insurance or the other. But the states have now picked up a state government insurance scheme because the center allocates a budget for healthcare. There's a central budget every year for healthcare, which then is given to the states, and then it's up to the states to really take the budget and see what they can do, to build sustainable solutions for healthcare. So I think the southern states have done much better than some of the northern states. And so the insurance for the general population, general public, has now picked up. And Aragonda started this model where I come from, the village where we all come from. And more than doing that, today we take care of 60,000 of the population around the village, and it takes care of education for the children, some kind of work or lifestyle for the grown-ups, because we feel that if we keep them gainfully employed, then it keeps them out of trouble. So there's skill development centers which today are training about 10,000 youth to be gainfully employed into different areas. It does a yearly screening program for cardiac, diabetes, and cancer screening. And so it kind of takes care of their healthcare needs. And in case they need an intervention, then they are insured. So, they can go to a private sector hospital, which we have, or the public sector hospital also has been adopted by us because we run a medical school there now. And so they can get into the district hospital and get treated. So I think this model has evolved so well, and that was one of the reasons why I was spending time with the Planning Commission and with the government trying to see if this can be a replicable model for some of the other states, and people can actually pick this up and try and do it in the smaller towns, in the villages, so that people are looked after, basically. So it's a lot of it is about financing and delivery and finding interesting financing models and trying to see. I do not believe that there is not, we're a poor country or we don't have enough money. There is money in the system. If we take 1.3 billion people and we halve it, and we say that this population can actually contribute 1 rupee a day to take care of their healthcare needs. It's a lot of money. We just have to find a way to channel that adequately to come back into the system to take care of their healthcare needs. So I think intrinsically there is enough money in the system to take care of their healthcare needs. So I don't think that is a problem which we need to talk about or worry about. Are there enough tertiary care beds? I don't think so yet, but it's growing, and it's growing at about 20%, and it will. The private healthcare is growing actually at about 48% now. Private sector healthcare is growing, and that will. The government is focusing much more on primary care and prevention, which I think with limited resources, that is what governments should do. And the tertiary care work and the high-end interventions should actually be worked in a public-private partnership model, and that is happening. The public sector, again, should focus more on education and research, and I think they're realizing that. So there has been a shift in the mindset and thinking, and I think that's important. But the last P in the, actually public-private partnership, but the last P, I thought, I added it in as a little dot, because I think it's about the people and it's about the people's mindsets. And if there is a shift in the mindset and in the way people can change their way of thinking, then it makes a huge difference. Many countries have done a lot of good work in the pursuit of sustainability. And I think there is a happiness index in Bhutan, which I'm fascinated about. And if we do what we do very well, then that should be monitored. And there's a cure versus disease management, because I think we have to look at disease management more than cure. Because curing always has to be done, but if we can tackle the disease early, it makes a difference. Population health needs much more of focus. We have to use artificial intelligence to really predict the onset of problems and disease, and that's required. It's not enough. Countries like ours use telemedicine a lot, because I think that is required, and it's not possible to reach the geographical challenge unless we use technology to reach it. But QALY is interesting, and a lot of research institutions are using it, and it's quality adjusted life year. Normally they look at infant mortality. They use different indices, but now they're shifting to actually quality adjusted life year. That has become one more metrics for monitoring people's healthcare, and I think that's really made decisions much better and much more focused. So I think there's been a shift in the mindset of not only the public sector, but the public and the private sector to work together and to be more focused. It's not just a single prescription or an answer for the healthcare of 1.3 billion people, which is growing. But I think the moves have been in the right direction, and I'm hoping that India as a country will actually have some models for the rest of the world to look at and to emulate, and that would probably be the best thing to answer. But while I was saying all this, I did not really mention the fact that the alternate systems of medicine, whether it's the Chinese systems or the Buddhist systems or India's alternate systems of medicine, should not be written off, because they bring a lot of value to some of the answers to healthcare. The problem is that we don't know enough. They haven't been tried and tested or written up enough for a doctor today to prescribe it, for a doctor in a healthcare system to actually prescribe it. It's still two parallel healthcare systems. But when these two systems converge and we have integrated healthcare systems, integrated healthcare models of delivery, we might have a few more answers in the future, and I'm looking forward to that too. Thank you all very much, and thank you for the invitation.
Thanks very much, Preetha, and a very helpful sort of laying out of some of the big themes and issues and challenges ahead. We've got just a couple of minutes for questions. I don't know if anybody's got a thought, a question for Preetha. I mean, just one thing that strikes me, and you talked about that question of the financing capacity. I mean, do you think there's any prospect within India that the federal government and the states will actually step up both in terms of direct funding and provision, or do you think going forwards really nearly all of the growth is going to come from private sector?
You know, the current budget for healthcare from 2%, which I'm even embarrassed to say, has went up to 2.5%. But we think by the time the 5 years are up of the present government, in my estimate, it'll go up another 2 points, because there is a very clear focus on healthcare. But where I see a gap and where it is a huge cause of concern is the central budget, as I said, is allocated to the states. And the states are not really using the central budget well enough. In fact, they have unutilized money in the system, which they don't know where to deploy. And that's why I think there's, policies are important. There has to be a mandate on how the money is, deployed. And these things are evolving.
And your sense is should that state funding go into provision of state services? You talked about primary healthcare, or should it be to funding private sector providers or partnership providers?
No, I don't think the central union budget should go into funding private sector, unless it's some public-private partnership which goes back into solving some of the nation's problems. But the state itself should, utilize the provisions to be able to do focused attempts. You'll find some states wanting to, like, for cancer, some state government might want to put up a proton project just because somebody like Apollo is doing it. And that's ridiculous, because you would take that money into cancer prevention, into basic intervention, and you would send anyone requiring it with an insurance backup into the private sector. So I think sometimes the state governments are trying to compete with the private sector on building these very high-end facilities, where they should actually be tackling the problems of primary and secondary healthcare and building access for the public, and then going into building these centers.
And the other thing which you touched upon with, for example, as you say, the systems around traditional medicine and so on, and we were discussing earlier, but this idea of the role of research and looking at some of the distinct disease characteristics and ways of approaching healthcare within India and the region. You see both a role for government and for private and academic funding to focus a lot more on a sort of an Asian model, as it were, and some of the specifics of healthcare
I
response
think
here.
now it's happening, and typically there is one research model which I'm personally very excited about, is the one I was talking to you earlier about, the Framingham study, which is done for cardiac disease, and it's like a baseline for prescription of medication for cholesterol, etc. Has been done on Caucasians, and it's on a Caucasian body with Caucasian genes. And as Asians, a lot of it actually has to be adjusted, like risk adjusted. There is no proper study on Asians, which will be like, a typical Framingham study. So we said, let's take that up and, let's do it in India and then make it a global study. So I think one of the institutions which showed some interest was Stanford. So I'm just hoping that, once we get the basic model out, then we'll get all the other institutions coming and working with it. So the Asian population is actually larger than the Caucasian population, but all the studies and research has actually been done on them. And so there is a lot of work to do on the Asian population in terms of research.
Great. Well, we could carry on discussing for a long time, and hopefully you'll be around for a little bit to answer any other questions over the next couple of hours. But Preetha, thank you very much indeed for coming.
Thank you, Andrew.
And let me call on my colleague Jeevan to now come to the stage for the next session.
Thank you.
Thanks.
Mm-hmm.